Hello everyone, so we're going to continue our discussion. Hello everyone, now we continue our discussion of to master the pulmonary system. Okay, so you get 45-year-old woman came in with shortness of breath, wheezing, cough, recurrent sinusitis, sinus infection. So what you would do, you check eosinophil. There is so recurrent sinus infections, and you see erythematous tonsil with white exudate, bilateral nasal polyp, and you will check CBC. CBC, you see eosinophil 25%, and L-defined opacities bilaterally. L-defined opacities bilaterally. And they ask about what's the diagnosis. This one is called eosinophilic granulomatosis with polyangiitis. This one, same as what is it called, Church-Strauss syndrome previously. They just changed the name. Okay, so what other associated features? Usually associated with asthma, allergic rhinitis, chronic rhinosinusitis with nasal polyp. Another thing, just like common variable deficiency causes recurrent sinus infection as well. Other thing, eosinophilic, this is the prodromal phase. Another thing, eosinophilic phase, more than 10% peripheral blood eosinophilia, and could cause migratory pulmonary opacities, causes eosinophilic enteritis, bleeding, obstruction, perforation, GI-wise, and then also causes organ-threatening systemic vasculitis. And nervous system-wise hits every organ system. This is vasculitis. It causes mononeuritis multiplex, peripheral nerve edema. It causes myocarditis, conduction defect, leading cause of mortality, by the way, conduction defect. Necrotizing glomerulonephritis, usually P-ANCA, and then in the skin it causes tender subcutaneous nodules, granuloma, and then it causes migratory polyarthralgia as well. Another thing causes migratory polyarthralgia is Neisseria gonorrhea. Alright, so let's go another case. 45-year-old man came in with kypho. Scoliosis, okay. Came in with fatigue and shortness of breath. And what would and then pulmonary systolic pressure. Systolic pressure is 55. What would the benefit from? Like, what is the treatment that would be helping this patient? This patient has pectus exudatum as well. So, intermittent non-invasive ventilation would be very helpful for this patient, just to help them breathe well. And patient with chronic respiratory failure from chest wall disease has shown to improve dyspnea, sleep disturbance, and mortality as well. Okay, and partially reverse cor pulmonale, because this patient has in cor pulmonale, like because of the kyphoscoliosis, they're not able to breathe well, so their arteries get stiffened, because hypoxia stimulates vasoconstriction and could affect the heart, cor pulmonale. So this one is very helpful. It's nice kind to help them better. Okay, now we have 60-year-old man came in with hemoptysis, anxious appearing, there is diffuse wheezing, okay, leukocytosis, and then CT shows bilateral, like cavitary lesions, and then they would ask like diffuse wheezing. So what would be the diagnosis for this patient? That's what the question is. Bilateral cavitary lesion. This one would be aspergilloma. Bilateral upper lobes, fungal balls, and cavities. This could mean aspergilloma. It's pretty risky, hemoptysis. So this also brings us to another one with massive hemoptysis. When you have somebody with massive hemoptysis, you want supporting measures like chest X-ray, ICU admission, airway circulation, resuscitation. You want to make sure everything is okay, and then you want to do CT chest and flexible bronchoscopy for localization. Right bronchoscopy is preferred for treatment if available. So if the bleeding is localized, you do arterial bronchial artery embolization by interventional radiology. Surgical treatment if uncontrolled bleeding recurs. Okay, that's one thing. But what if it's not localized? Then conservative management or close surveillance would be a good idea to do. Alright, so now we have another patient came in, 85, Came in with cough, shortness of breath, decreased responsiveness, you know, decreased responsiveness. And then exam, if we decrease the breath sounds on the right, decrease the breath sounds on the right. And so you do chest x-ray showing pneumothorax. What's the best next step? You want to do chest tube. The best next step, you need to do chest tube. This is pneumothorax. This is dangerous and the patient could be dying right now if you don't do it. Alright, now we have 73-year-old woman came in after being unconscious, founding unconscious at home, coma. So she was intubated, and the questions are how to decrease ventilator pneumonia. Okay, so you can do oral care with antiseptic. Other things that could decrease risk of ventilator associated pneumonia, that brings us to discussion how to decrease ventilator associated pneumonia. There are things that could decrease it: hand hygiene, non-invasive ventilation when possible, daily sedation, weaning protocol, orogastric tube. These are in general cleaning guidelines, general guidelines to prevent ventilator associated pneumonia. And then you want to prevent aspiration, because this is not good. You want to so you want a semi-recombinant position, 30 to 45 angle. You want to do aspiration of glottic secretion suction, endotracheal tube cough pressure more than 20 mm H2O. And then you want to reduce colonization by oral antiseptic, routine prophylaxis is not recommended, and then avoid protein pump inhibitor, avoid H2 blocker agent if possible. This decreases risk of ventilator associated pneumonia. Okay, now you have another patient, 42-year-old, came in with substernal chest pressure. So chest pressure, dyspnea, nausea. Okay, what would you do? And then all the vessels are collapsed. You want to start pressors. All the vessels are collapsed. What's next step? You want to do intra osseous line insertion. So if all the vessels are collapsed, you want to do intraosseous cannulation. Can provide rapid access. You just put a rapid access in septic shock, cardiopulmonary resuscitation when IV access cannot be obtained, when it's hard, then you would do that. Okay. Another case, you see someone with cough, fever, he's in his 70s, shortness of breath, you see crackles as well, and so you get intubated. Okay, and they ask you what is the next step in management. So this patient, like, what is the goal? The question is asking you what are the goals for the ventilator, being on the ventilator. What are the goals? So we have a few things. Our goal to be volume assist control. Okay, in the mode tidal volume, you want an 8 milli per kilogram, like reduce 4 to 6 milliliter per kilogram over 1 to 3 hours. And then PEEP, we want to keep it between 5 to 15, and high PEEP for moderate or severe ARDS. And plateau pressure, you want to keep it below 30. Respiratory rate, you want it below 35. And pH goal above 7.25. And then PaO2, you want it to be 55 to 80. And then pulse ox, you want it 88 to 95. So these are for ARDS setting, what you want, right? So this patient, you see PaO2, his patient's hypoxic. Okay, so they tell you what variables can you adjust in the ventilator to change the oxygen. So this patient PaO2 is 48. This is low. So you have two things: either increase the FiO2 or increase the PEEP. Okay, FiO2 is already high, like 80%. So what you would do, you increase PEEP. Okay. PaO2 is 48. Okay, so this is what you would do: increase the PEEP. All right. Now we have another case. It's easy case. Chest pain worse with breathing. Worse with breathing. Best next step, you want to give NSAID, indomethacin. This is a pleuritis. And we got another case. Someone 33 came in with a chronic rhinosinusitis. So in addition to tapering doses of steroid, they were asking you what would you do. And this patient have chronic rhinosinusitis. The other things they can bring, there's wheezes, bilateral wheeze, conjunctival injection, rhinorrhea, rhea, wheezes, conjunctival injection, and a patient is given methylprednisone and albuterol, and they're asking you, how do you treat that? This is called aspirin or NSAID exacerbated respiratory disease. So usually this is how it presents: wheezes, rhinosinusitis, facial erythema, headache. Ibuprofen usually worse than that as well. So the way you treat, you want to give a Leukotriene antagonist like montelukast. Okay, that would be a good option, because now this brings us to the discussion of aspirin exacerbated respiratory disease. Usually it represents with chronic rhinosinusitis, like in this case, asthma, wheezing, aspirin or NSAID sensitivity, patient taken ibuprofen recently, and then ingestion can result in acute asthma exacerbation, profuse rhinorrhea, conjunctival injection, erythematous flushing of the face, facial erythema, they tell you, and symptoms begin 30 minutes to 3 hours after ingestion. So how do? You avoid NSAID if possible, add leukotriene receptor antagonist like montelukast, zeferlukast, and then consider aspirin desensitization if aspirin use required for other cases. Okay, so that's kind of the issue. So instead of giving like NSAID aspirin, you can give leukotriene antagonist. Once you give leukotriene antagonist, this is going to prevent the vasoconstriction, the increased permeability. It's going to prevent the leukotriene. So you'll have less permeability, less vasoconstriction, less vasodilation, because leukotriene causes vasodilation, hyperpermeability, congestion. So we inhibit that, okay? So now let's go to the next one. You have 63-year-old came in with shortness of breath at night, like waking up from sleep, right? So what would you do? There is JVD distension as well. So this is not good, right? JVD distension. And then they're gonna do the patient's hypoxia as well. Hypoxia, hypotensive, okay, tachycardic. And you're preparing for intubation. What do you do the next step? You want to do emergent bedside echo. Emergent, because this patient could be cardiac tamponade. You could save their life, okay? Or if there is suspected PE, you want to, maybe there's massive PE that developed right now, and you need to be consult interventional radiology or invasive cardiology to take the clot out. So this is now bring us to the discussion. If you suspect PE, what would you do? You assess first. You make sure the hemodynamics. If they're unstable hemodynamically, there's high probability for PE. You want to do echo. If there is right ventricular strain, then it's BE confirmed. Okay, you want to consult the interventional, maybe do CT. You have to take it out, start anticoagulation, right? What if it's not critically ill? Okay, then you can do CT, angio, or VQ scan if somebody's not critically ill. Okay, if it's positive, then confirmed. Okay, but what if the patient is stable hemodynamically? If there is high probability, then you do CT. If there is low probability, you can check D-dimer. If it's elevated, you do CT. If it's normal, then PE ruled out. So that brings us to the discussion of PE. Okay. Now just to review, we talked about bedside echo for PE. And we talked about montelukast for rhinorrhea, aspirin-induced wheezes. Respiratory disease, increased PEEP if their hypoxia, intraosseous insertion is very helpful sometimes. Oral antiseptic to prevent ventilator-associated pneumonia. Chest tube is helpful to somebody who decreases breath on the right side. Aspergilloma is important in intermittent non-invasive ventilation. Eosinophilic granulomatosis polyangiitis can cause wheezes and eosinophilia, peripheral eosinophilia. And that summarizes the second part of the pulmonary system.